Thank you. So we're going to attempt something now that's never been done before in the history of SCAS. If it works, it'll be awesome, glory and fame forever. And if it doesn't, then you'll be laughing all the way to the train. But that doesn't matter as long as you absorb the key messages that we're going to attempt to get out to you now in a slightly unusual way. But you need to do some preparation. So if you can take your card that your name badge is on and have a look at the back where it has these QR codes. And if you're watching online, the QR code hopefully will be available to you any second now. Scan the QR code with your phone and that will take you to SCAS, which we're going to use to do some interactive audience participation. So at various points during what you're about to see, we'll ask you some questions and we'd like you to respond using the SCAS app. So I'll just give you a few seconds there. Scan the QR code, get yourself organized, and then we'll be ready to begin. So, set your phones on silent because you don't want to disturb the concentration of our highly trained simulation team. We've handpicked them for today's demonstration. We've conditioned them for days and days. We've prevented them from practicing together because that would spoil the fun. So no rehearsals have been done. And we brought them all the way here to Edinburgh for this moment. So, team, are you ready? Team, are you ready? Oh, they're outside. Yes, there's a thumbs up. Okay, action.
No, I don't think either. No, I don't think either. No. Yeah. Right, hang on, I'm going to put the phone down. Yeah, I can hear you. Yeah. That's it, yeah. Right. Okay, well, yeah, sorry about this. You know, yeah. You got a sense of fucking help, mate? Got a sense of help. Oh, come on. Come on, mate. Come on, mate.
Hi, I'm Marisha. I'm the good sound responder. Can I take over the CPR?
Yeah. This is my mate Dave. We were out for a few beers. I worked with him. Don't know much about him. He said he had chest pain earlier on, but I just sounded like this, and he's.
So, when you hear that sound, that means we're going to pause the devastatingly exciting resus to ask you some questions. So, first question. You're all familiar with the chain of survival. Call for help, and then early CPR to buy time. But the question is, how much time? What can chest compressions really achieve? So the question, hopefully is coming up on your Slido just now, is what proportion of normal perfusion, normal blood flow, can chest compressions achieve for the brain? You've got a choice of answers there on your Slido. Please, could you indicate your answer now? What percentage of normal cerebral perfusion do you think somebody doing good quality CPR can achieve? So, all had a chance to vote. Mr. Slido, can we see what people's answers have been? So we gave you the option of 40%, 60%, or 85% normal cerebral perfusion, and you guessed, what did you guess? We should have some little graphy lines coming up just now. Put your hand in the air if you thought it was 85. You were wrong. Put your hand in the air if you thought it was 60. You were also wrong. Who voted 40? Pat yourselves on the back with that hand because you got the right answer. Thank you, Slido. All right, excellent. Okay, back to the resuscitation.
Yeah, so he just collapsed. He said he had chest pain, and I don't know what this. Come on, mate. Hey, come on. Hey, wake up. That's gonna hurt him.
Excellent. Can you just go back on the chest? Just with your fingers. Okay, we'll get the pads on. Emma, Lee, are you okay at your position? Are you okay if I just take team leader role? Okay, what's your name? Keep going just now. Arij, see when you come off the chest, Leo, take over, okay?
Okay, just freeze for a second, guys. And let's hold the demo. We've got the crew have arrived, they've taken over. We're just going to skip past the next one. And then we got to CPR. Now, you'll see what's happened here. As the team have come, they've swapped over the CPR operators because CPR, crucial though it is, it buys us some time, but it doesn't stop the clock completely. It only buys us a period of time, and only if we do it maximally efficiently. So, my question to you is, how long will it take before one of our responders here gets fatigued and their CPR quality will drop? How long does it take until fatigue means the chest compression quality will drop below the level of effectiveness? So you've got some options on your Slido now. How long do you think you've got before you need to swap for another operator or things are going to go bad? Okay, please vote now. That's great. All right, should we see what people thought? What did you think? So your options were 15 minutes, 7.5 minutes, or 2 minutes, and nobody was fooled, or very few people were fooled. The answer is, of course, 2 minutes. And I just want to show you a graph. We can go back to the slides for a second. There's a lot of research being done on this, and here's the very, very interesting graph. It shows a couple of things. Minute 1, minute 2, minute 3, minute 4, minute 5 along the x-axis. And then adequacy of compressions on the y-axis. Were they deep enough? Were they fast enough? Was there recoil? And you can see that there's a line across here at 70%. Once you get below 70%, your compressions just aren't working. Sometime during the first minute, most people's compressions will drop below 70%. Almost always by the end of the second minute, even with well-trained responders, the effectiveness of CPR will drop below 70%. Using things like real-time feedback, if you use a puck, you use a metronome, that will help, that will preserve your quality. But 2 minutes is the maximum time you want anybody doing manual CPR before you swap, if a swap is available. And here's the extra bonus interesting fact. You see the red line over here at 250 seconds. That's when you begin to become aware of your fatigue. Your CPR becomes rubbish sometime during 1 and 2 minutes, but you start to feel tired after 4 or 5 minutes. So don't wait till somebody wants to stop. Swap them out after 2 minutes maximum. Okay, let's get back into it, folks.
Okay, Arij, if you just stay off the chest just now, guys, I'll keep a wee eye on the clock here. Okay, stand clear. Back on the chest. Arij, can you tell me what's happened?
He suddenly collapsed.
He just collapsed. Was
Yeah.
he complaining any pain or anything beforehand?
No, he wasn't complaining at any pain. So the bystander actually saw him unconscious suddenly unconscious.
Okay, no worries. So we've not got much history. No, that's okay. Don't worry about it. Arij, are you okay just to switch out every 2 minutes for CPR? I'll let you know when the next one is. Are you happy with the airway and everything?
Just hold tight.
Perfect, no worries. And Lee, are you okay?
Yeah.
Good stuff. So we've got a shockable rhythm. We've not got much history. We try and work through some of our reversible causes. You can let us know how the airway is, Emma, when you ventilate. Okay, are we getting good rise and fall there? Yeah? Excellent. There's no any blunt trauma or any trauma to his chest or anything. We don't have any medical history whatsoever, so it's going to be quite difficult to work out our reversible causes. It's a nice warm environment, it's summer. There's no clinical signs of tension pneumothorax, toxins, no. Okay.
So, the team are into their second cycle, they've delivered a shock, they're now doing nice effective chest compressions, looking after the airway, thinking about getting IV access. And we're going through possible reversible causes. What can we do to potentially reverse what's caused this cardiac arrest? The next thing I want to discuss, though, is compression fraction. During all of this busyness, while we're thinking about other things, reversible causes, putting in an airway, getting IV access, it's very important that we stay on the chest, that we don't interrupt those chest compressions. Now, why is it important? Well, it turns out the answer to that question is really, really interesting. This is a graph from some pig work done by Carl Kern. Those of you who are old will remember that Carl came and spoke actually at one of the original SCAS conferences, 2015, in fact it was, so 10 years ago. And this graph shows two things. It shows the pressure during CPR in the aorta, which is the yellow line, and it shows the pressure during CPR in the right atrium, which is the purple line. And you can see each of these spikes is a chest compression. Every time you press on the chest, it pushes up the pressure in the aorta and the right atrium. Now, the blood flows into the heart muscle, getting the heart muscle ready for defibrillation, making the heart muscle ready to recover only during diastole, only during the decompression phase, only when you take your hands off the chest or up from the chest. And you can see that the pressure that perfuses that heart muscle is the difference between the purple and the yellow lines, coronary perfusion pressure. Now, the interesting thing is not that it's aorta versus right atrium. It's not that it's only happens during diastole. It's that it gradually builds up over compressions. See, there are 15 compressions there, back from the days when we used to do 15 to 2. And you can see that optimal coronary perfusion pressure doesn't start to happen till almost at the end of the 15 compressions. If there's a break in CPR and you start again, it takes several compressions before you build up to optimal coronary perfusion. That's the key message. And if you look here at the same kind of thing on a different scale, you can see 15 compressions, pause for 2 breaths, 15 compressions. Each time it's taking several compressions to build up to optimal perfusion. If the interruptions to compressions while you're intubating, while you're putting on pads, while you're trying to get access, while you're changing operator, are more than just a second or two, that is catastrophically bad for heart perfusion. And ability to successfully resuscitate is inextricably linked to coronary artery perfusion. So, the question I have for you, so Slido's at the ready, folks. What percentage of the time do the guidelines, including JR Calc, recommend you should be doing chest compressions without interruption? What percentage of the time should you be on the chest in order to have optimal chances of resuscitation? You need to minimize interruptions. You need to stay on the chest as much as you can, even when you're putting on pads, getting IV access, messing around with the airway. But what's the magic number? Great. Mr. Slido, can we have the results, please? So your options were 65%, 32%, and 80%, and well done. The vast majority of people have got the right answer, which is 80% of the time. Now, 80% might not sound like much, but that is very difficult to achieve, right? To get 80% on the chest time, you've got to be focused on what you're doing at all times. So well done, folks. Thank you very much, and please continue.
Let's get back in the chest.
Is it you next?
Okay, so we're coming up to the 2 minutes, guys, and then we'll do a rhythm check again. Arij, are you okay? Just when, if we check the rhythm and we need CPR again, if you can take over. Okay, let's do a wee rhythm check.
Okay, still in VF, back on the chest.
Am I on? I am on. Good. So we've come to a point where we are going to be wanting to put in another shock. And we need to be thinking then about how we deliver that in a timely manner. We always want to do it safely. We also want to be thinking about how we do it in a timely manner. Just thinking back to that slide about the coronary perfusion pressure. There's a direct correlation as well between a high coronary perfusion pressure and a shock that's going to work. So if we're going to be working hard to try and get this person back, optimising that shock is obviously very important. So your Slido question, I've not got it exactly, but in your phones, is how many seconds do you need to leave after CPR to significantly reduce shock success? As in, how long should you be off the chest at a maximum? Like, how many seconds do you need to leave after CPR to start reducing that shock success? All voted. Let's have a little look at the results then. Have you got a Slido result available? So we had options less than 5 seconds, less than 10, or less than 20 seconds. And again, most people have got that right. So we should be off the chest at that pre-shock pause for a maximum of 5 seconds if we can. And actually, 5 seconds is possibly quite a long time in this context. Can we go back to the slides? Thanks. So here's one graph of one study. Numbers aren't huge, but this is showing over time a gap, increasing pre-shock pauses versus the shock success. Again, this is done on poor pigs. And is this really showing, this study, that over time, the longer you're off the chest, the less likely you are to have a successful shock for the same patient, if you like. And there are other studies that show this it could be even worse than that. So how can we optimize this? Well, one tip, one suggestion might be when you're coming to that rhythm check time, that whoever's the team leader asks for everybody else, apart from the person doing compressions, to come away from the chest and only leave the person doing chest compressions while the defib is being charged. That then allows for the person delivering the shock to be much safer in terms of only needing to confirm that one other person's come off the chest before they put the shock in. And it can also mean that between the chest compressor and the person delivering the shock, they can coordinate it so the person delivering the compressions can come off the chest, shock goes down almost immediately, and then it's straight back on the compressions again. And that way it's most likely to optimize that shock for success.
So Arij, if you just stay back just now, we're going to charge up.
Off the chest.
Arij, if you go on the chest once we're ready. Perfect. Aye, IV access, and we'll start thinking about getting prepared for some drugs.
So, just when you thought it was safe to go back to resuscitation, IV access, so intravascular access, and some drugs. That's what we're going to talk about now. So, crucial part of resuscitation this patient has been in VF, they've had a couple of shocks, they still haven't responded. We now want to get some access because we want to give them other medicines to try and optimize their physiology to make them more resuscitatable. But there's more than one way to get intravascular access. You can put in a venflon, a cannula, into hopefully a more proximal vein, or you could try an intraosseous nail, either in the humerus or in the tibia. And all of them have their strengths and weaknesses. What I want you to consider now and answer on the SLIDO question is, which of these methods is associated with better clinical outcomes? You've got 3 methods on your question there, and I'd like you to arrange them in order of priority, from the best to the worst, with respect, in a general sense, to clinical outcomes. So on your Slido, arrange those 3 options from best to worst. Great job. All right. Well, wait and see, wait and see, wait and see. Yeah. It's doing great. This is. Right. Okay, time's up. Answers, Mr. Slido, please. So rank the 3 methods, and do you know what? It's almost as if you read the answers in advance. So the answer, of course, which is the best method? The answer is, oh, hang on. It depends, okay? Intravascular access has been associated with increased ROSC, though there aren't very firm clinical studies showing that it improves survival. But the drugs get in quicker through an intravascular route than they do trying to squeeze it in through the bone, okay? So intravascular access is associated with more ROSC. However, sometimes intravascular access is difficult or impossible. And then without delaying, you want to go for intraosseous access. Faffing around trying to get a cannula into a patient that can't be cannulated in the context of cardiac arrest is going to cost time, so go for IO. But then the question is, should you go for IO in the humerus or in the tibia? Now, all other things being equal, there's probably a marginal benefit in terms of speed of drug delivery in going for a humeral IO nail rather than tibial. It's closer to the heart. I guess it makes sense. Okay, so my suggestion is that the ranking should be, yes, it depends, but all other things being equal, assuming you can get it, IV access into the ACF or proximally followed by IO in the humerus, followed by IO in the tibia. But of course, the best access is the one you can get quickly to enable your resuscitation. Can we go back to the slides for a second? Thanks. And there you go. Best might be quicker, slower delivery, but IV access is preferred if it can be established without delay. IO is, of course, acceptable and should be used without delay if IV access is difficult. Great. Thanks, guys. Back to the resuscitation.
Okay, so we'll get some IV access. Emma, we're going up to the iGel as well. Perfect. Okay, Lee, the drugs we're thinking about, I'll just check them in my GR calc just now. We're thinking about adrenaline, indicated in cardiac arrest. No contraindications in this situation. If we stay in a shockable rhythm, we're going to give it after the 3rd shock. And we're thinking about amiodarone. Again, cardiac arrest, shockable rhythm, we're in. If we stay in that, we're going to be thinking about that. And we'll do our drug checks when we're ready. Okay, Arij, are you okay? Yep. You okay, Emma? Have we got end-tidal CO2 as well? Yeah, perfect. And we've managed to get IV access, okay? Fantastic. Equal rise and fall, good. Yep. stuff. Okay, this will be our last cycle, and then we'll do a rhythm check. Okay, we'll do a wee rhythm check. That's our 2 minutes up. We finish the cycle. Okay. So after these 2 vents, we'll do a rhythm check, guys. Okay, we'll just keep. Okay, Aries, you stay off the chest just now. Still in VF. Good.
So, we've come to a point where we're now well established. We've optimised as much as we can. We've got access. We're managing the airway. We've now got end-tidal CO2, so we can keep an eye on that as well and learn from that too. We're coming to a point where we've had a shock, and we're about to have another shock. So what do we do if it's not working? The shocks aren't working. We keep on trying the same thing, and we're not getting any success. We're now in refractive EF. What are we going to do? There's lots of different options. Here are some of them, some of which apply to us as ambulance clinicians. So on your Slido, it's now select which of these you think are the priorities. Or more specifically, which ones are the recommended options for us? Are we done? Let's have a look at Slido and see what we're saying. Still a couple coming in. So we have had 3 shocks. So in a shock of rhythm, quite correctly, we need to be thinking about drugs. For us, it'll be amiodarone. Lignocain's an option in some places too. So certainly that is one of the recommended next steps we take after we're given 3 shocks. High quality ALS, good chest compressions, all the rest of it. We've optimised that, that's great. And thankfully, a lot of people have picked the next one as well, which is recommended, that after a number of shocks, if you're not successful, you want to change the pad position and try a different position, different vector. Some part of that heart muscle has initiated this VF. And if your shock isn't going through that part of the heart muscle, it might not respond and revert back to sinus. So by changing your pad position, you're giving an alternative pathway for the shock to go through the heart, and possibly you'll have success after that point. After 3 shocks, it's possibly a good time to start thinking about that. So we're going to come back to the slides, if that's okay. We're quite correct. That's a high-quality ALS, amiodarone, and then a vector change. And then in this next cycle, we'll try and optimise that and change pad position.
Okay, so we're going to, did we deliver that shock? Yeah. Aye. Full chokes in. Okay.
Adrenaline 1 in 10,000. Expiry is December 2027. So that's your adrenaline.
Arid, are you feeling okay? We might get Emma to go in the chest actually in this next 2 ventilations. Emma, can you go in the chest now? Thanks.
Okay,
just because you've just done some CPR there. Excellent.
30 milligrams. Expiry is December 2027. Okay, I'm going to flush this through with 20 ml as well.
Excellent. Would you be okay, Lacey, after the next one, we'll think about changing the pad positions? We're getting good rise and fall still, Emma, yeah?
Sodium chloride is 09/2025.
Okay. I'll mark it, it's okay, I've got it here. So we've given 3 shocks, we've got our drugs in, we've got eye gel in, we're getting good rise and fall.
20 mil flush in there.
Are you okay, Arij? Okay, so what we'll do is when Emma does the next two ventilations, we'll get the front pad on and then we'll just go back to CPR and then we'll sacrifice the further two ventilations after that. Okay, so the next ones we won't ventilate, we'll just roll the patient over and get the pad on the back, if we're okay with that. Okay. Let's go. And we'll go back into our CPR. Harry, do you want to come round to that side just now, just in case we... And that's us... Yeah, that's us coming up to our 2-minute cycle as well. Yeah, we analyse. Okay, that looks like a normal sinus. Yep, let's check for a pulse. Yep, we've got a pulse. Okay, let's...
Oh. It's not quite finished yet, not finished, no, not finished, sorry, no. Just congratulating them so far. So we've got ROSC, so now what? That's not the end of the story by a long shot. It's a good place to be, but that's certainly not the end of the story for our team and certainly not for the patient. So the question now is, what do we do? What are our priorities now we have ROSC? And rather than giving you a multi-choice on your slider, you should be able to just write your own thoughts. It's a word, 2 words of what you think the priorities are now. And then we'll just get a sense of what people think. Lots of things to do. What should the priorities be? Still seeing lots of typing, so I'll wait a wee second. Shall we have a look? See what people think? If we can get the slide up. Yeah, there's some interesting thoughts, isn't it? Still coming in. So let's think through just a few of the priorities, and of course some of them are going to be case dependent, but stabilise the patient, that's a nice one. Let's not rush to pick them up and take them out of the house, wherever they are immediately, lest we put them back into VF. So spending a little bit of time to stabilise them is going to be really helpful. So we want to do an A2E assessment and systematically choose to work your way through your A2E assessment. And as you're going through, make sure you're addressing anything that you're finding. There's still some reason this person went into cardiac arrest, and if we can still identify that once they've got ROSC, then we're more likely to be on the right path for giving the correct treatment and taking them to the correct place. So we want to be careful with our ventilations as well. We've had capnography on, and that's been really helpful during the cardiac arrest. That will have risen. Now we have ROSC. And we want to carefully ventilate them, not to hypoventilate them or hyperventilate them. I'm looking for a normal capnography range. So if we're somewhere over 6, we're probably going to want to increase our ventilation rate a bit, about every 3 seconds, 3 to 4 seconds, just to try and blow off the extra CO2 and bring that capnography level back down again. Otherwise, we're looking for about every 6 seconds, about 10 a minute, which sometimes is a bit slower than it feels like it should be, given the effort we put in. As well as that, we're probably going to want to do an ECG on most patients. Your initial ECG after you get ROSC might look a bit wacky. So we want to do an ECG and then probably repeat it a couple of times or more on the way to hospital. We're also going to want to try and get their blood pressure around about 100 or above. And that might mean a fluid challenge. Try for a 250 bag with saline and have another check again. Maybe repeat that. We also have adrenaline as an option. But let's also remember that this event has been incredibly painful for the person. If they're at all responsive, they're likely to be in quite a lot of pain. And they may have been in pain before it. If they'd had an MI, they might already have been in pain before their cardiac arrest. So we want to be thinking also about some pain relief. Some of the agitation that we sometimes see might actually be them responding to the pain they're feeling. And if you look at your JRCAL, there's a nice little line in it which advocates starting some IV paracetamol and supplementing with tiny little bits of morphine. Also then make a plan for extrication. And then once you're in the ambulance and travelling, it would be good to raise the back of the bed a little bit. About 30 degrees tilt up is going to be helpful for the blood flow to the brain and be useful just for that ongoing care as we take them into hospital. Lots of other things we can do, but we're out of time. Thank you very much.